Welcome everyone, good evening or good afternoon or perhaps good morning. And we just welcome you to the last webinar of this year for PT and OT professionals. And this one is titled the LSVT BIG Year in Review, Research and Clinical Updates in 2021. So we're so glad that you could join us. My name is Laura Gousset. I'm a physical therapist and one of the LSVT BIG certification faculty, and I'm joined by my colleague, Julia Wood, an occupational therapist and also one of our LSVT BIG training and certification faculties. I won't read our bios here for you, but they are here in case you need to save the handouts for turning in for self-reported CEUs. In terms of some brief disclosures, we have financial and non-financial relationships with LSVT Global, including a preference for LSVT BIG as a treatment technique. I am an employee of LSVT Global, and Julia is a consultant for LSVT Global, and we receive lecture honorarium for our webinars from LSVT Global. In terms of logistics, right now your microphones are muted if you're joining us for a live webinar. At the end of the webinar, you'll have an opportunity to ask questions. However, we want to make this webinar as interactive as possible for you. And so throughout the webinar, feel free to type in your questions in your control panel. It might be either titled questions or chat, either one. If you're having a hard time seeing your control panel, you might be able to see an orange arrow on the side of your screen. If you click on that, that should expand your control panel and you should be able to see all of the options as well. If you're having any difficulties with audio or video on your control panel, there's a little audio tab that you can click on and test your audio. And Julia is also on deck for some background support while I'm speaking, and I'll do the same for her when she's presenting as well. At the end of the webinar, when you log off, there will be a survey that automatically pops up. You'll also receive it by email. You only have to answer it once, but we do appreciate your responses as we use them for not only feedback, but future webinar planning as well. And right now, we are just about to launch our 2022 webinar schedule. So really appreciate your input because that helps us to decide what topics to feature in the coming year. A little bit about continuing education units. You can self-report this activity if your state allows it. So be sure to check with your state physical therapy or occupational therapy licensing board to see if they accept non-pre-approved C activities. You do have to attend the full webinar in duration, and this webinar is 1 hour long. If you do, we'll email you a certificate within 1 to 2 weeks that'll have the date of the webinar, the title of the webinar, as well as your name as well, so that you can use that for CEs. The learning objectives for tonight's webinar are as follows, and these really reflect the 5 articles that came out in 2021 that we'll be discussing tonight. So first, recognize the potential for LSVT BIG to affect occupational performance and hand function in people with Parkinson's disease. Summarize considerations related to the provision of LSVT BIG via telehealth in people with PD. Highlight factors that may help people with PD to sustain treatment gains following LSVT BIG. State how LSVT BIG was adapted and was able to improve function in a person with advanced PD. And paraphrase how intensive individualized therapy, including LSVT BIG, can benefit people with PD. So we're going to kick this webinar off tonight with a poll. This webinar is normally provided only to LSVT BIG certified PT and OT clinicians. However, we've opened this one up tonight to all professionals, so we'd really love to know who's joining us. And you can see the options here, but let me open up the poll so that you can answer it live, and I'll give you around 30 seconds to make your selection. So you should see this poll launched right now, and I'll just watch for all of the votes to come in. Maybe a few more seconds. Looks like almost everyone has voted. All right, and I'm going to go ahead and close that poll. Looks like about 80% of you have voted. And as you can see, about 70% of you are PTs or PT students, 16% OTs or OT students, 8% SLPs, 2% people with PD, and 3% other. So thank you so much for that. All right, I've got one more poll for you to answer real quick now that you're a polling expert. If you are a PT or OT professional or student, we'd love to know if you're LSVT BIG certified joining us or if you're someone that's not yet certified. So let me go ahead and launch that poll. And this one shouldn't take you very long to answer. Okay, looks like we've got pretty much everyone in. And 91% of you say yes, you are LSVT BIG certified, and 9% say no. So thank you again for sharing that. That helps us quite a lot when we are thinking about how to present these research studies. And these are the 5 studies that we'll be going over tonight. Julia's going to kick it off talking about occupational performance and hand function in people with Parkinson's disease after participation in LSVT BIG. And this one is really hot off the press. It was literally just published a few weeks ago. So excited to share this really great study with you. I'll be talking to you about a case report on the utilization of telehealth to deliver LSVT BIG treatment to a person with young onset PD. And then Julia is going to present the next 2 studies, one on the short-term effect and retention of LSVT BIG on quality of life in a 1-year follow-up with a person with Parkinson's disease, and also the effect of LSVT BIG on motor performance in a person with severe Parkinson's disease. And that was a case report as well. And then lastly, I'll be wrapping up the night with one that came out of Germany, looking at the effects of LSVT BIG and conventional physiotherapy on non-motor and motor symptoms in PD. And this was a randomized control trial that compared 3 exercise models. All right, one more poll before we start our first study of the night. So poll number 3 is if you have LSVT BIG in your healthcare organization, who provides it? Is it PT that does it solo, OT solo, PT and OT working together, or maybe LSVT BIG is not offered in your organization? So let me find that poll. And you should be able to see it on your screen now. Please vote. And I should have answered an I don't know as an option. So if you don't know, that's okay. All right. And let me go ahead and share that one with you. And it looks like 38% PT only, 6% OT only, 34% PT and OT, which is great. Julie's going to highlight a study on that. And then 23% LSVT BIG is not offered in your healthcare organization currently. All right, so thank you for all of those. All right, so I'm going to turn the mic over to Julia, who's going to get us started with this first study that just recently came out.
Thanks so much, Laura. And thank you all so much for joining us. Nothing I like more than discussing some research. So we're going to kick it off with an article that I really like a lot and actually was introduced to earlier this year, which looks at occupational performance and hand function in people with Parkinson's disease. And I think, as we all know, in treating people with Parkinson's disease, we often see, issues around self-care or instrumental activities of daily living, socialization, all of these issues with occupational performance, as well as issues with hand dexterity. So the objective of this was really to examine, the impact of occupational performance and hand function outcomes for people who have Parkinson's and participated in LSVT BIG. And so this took a look at 66 individuals with Parkinson's who were seen in an outpatient hospital-based setting. And the measurements that were used were the Canadian Occupational Performance Measure, or the COPM, to look at areas of occupational performance. And for those of you that aren't familiar with that assessment, basically it has different sections related to self-care, to instrumental activities of daily living, socialization, and the person is asked to prioritize the tasks that are most important to them, and then also rank their performance with those tasks, 0 to 10, and their satisfaction with doing those tasks. I will say, for those of you out there that maybe have used it, an interesting thing I always found with my patients with Parkinson's is often they would kind of push back and say, well, why would my satisfaction be any different than my performance? And so I will admit that sometimes I went to using the PSFS, or the patient specific functional scale, which is a little similar, but it's that they only really rank their performance. So just to kind of give you a caveat or a comparison of what that measure looks like. They also use the Minnesota Manual Dexterity Test, which looks at fine motor coordination in one hand, and also bilateral integration, which is a little different than the 9-hole peg test. And then they also measure grip strength using a dynamometer. And oh, I should mention too, the grip strength was done with a standardized protocol where you do the three tests and you take the average of the tests on that hand. So it was using that norm as the baseline. All right, next slide, please. So what they did is they did a retrospective chart review, and they extracted outcomes from patient charts in this hospital-based outpatient session or setting. The LSVT BIG program had been delivered by a certified OT that I believe it said had some 20 years experience. So this was a very seasoned, experienced occupational therapist. And then the physical therapist, I believe, also had 10 to 20 years of experience. And so the OT was delivering it 2 times a week, the PT 2 times a week, to deliver that 16 session protocol. And as you all know, that's something that we definitely promote a lot. In my setting at the University of Pennsylvania, in our Center of Excellence, we use this more often than not, because we really felt that the combination of the two disciplines collaborating and working together provided a level of interprofessional and interdisciplinary care that was really supreme. And so what's interesting here is that they, on the COPM, some goals or some areas of occupation that came up. One was washing feet independently with left hand. Another one was putting on their belt independently. Another was increasing strength for holding a baby. And as we all know, a lot of times it's not actually strength. Sometimes that's the perception of the patient, is that they feel weak. It's more the amplitude of movement, or maybe their balance, or something about their motor performance. And then also on here, improving brain memory. And so we know that LSVT big is not necessarily, we haven't done studies to show that we can target cognitive function with it, but a lot of times with exercise, and especially more intense exercise, the research does suggest that sometimes people do have some changes, or note some changes to their cognitive function. All right, next slide, please. And so the results were, in the COPM, I'm not sure if I stressed enough that it's really the participant identifying what their occupational goals are. So we're not telling the person what they're having trouble with or what they're doing poorly with, but we really have the participant, or the client or patient identify those. And we really saw significant pre to post changes here. So the improvements ranged from 3 to 6 points for both their performance in their identified or selected task and their satisfaction. And I think in one of the slides coming up, we'll get a little bit more. A lot of the tasks chosen are very common ones we see, right? Handwriting, lower extremity dressing, buttoning and fasteners on clothing. And so also it's, so that's more of a client rated measure, right, with the COPM. But then with the grip strength, even though that wasn't targeted, we weren't doing, exercises in this, or, standard rote therapy working on grip strength, they showed significant gains in both hands. So you'll notice here that the right hand, the median score improved from 55 to 64 pounds, which is definitely a significant gain. And then the left hand, an increase from 52 to 63 pounds. So we're not even targeting grip strength, and there was such an improvement. And then lastly, that MMDT that's looking at fine motor coordination showed a significant improvement where there was a median time decrease from 124 seconds to 119.5 seconds. So definitely saw changes to manual dexterity as well. And next slide, please. So now I would like for you to type into the chat because we want you guys to kind of process and think, about how this could be useful for you. So what is one way that you think this study could potentially apply to some aspect or element of your own patient care? And there's no right or wrong answer. We're just trying to see kind of what you guys think, the practice settings that you're in, how you think this information could be helpful. All right, and we'll give you some time to do that. So the clinical relevance, really from the authors, I think, and myself too, is that, participation in LSVT BIG can improve perceived occupational performance. So right on that COPM, they're rating their perception of their satisfaction and their gains. But also it produces gains in both their hand strength and their hand dexterity. And so we think it's really important. You notice tonight at the beginning of the webinar, the disparity between PTs and OTs here tonight. It's like all PTs and a few OTs. And I love my PT colleagues. I'm glad you guys are with us too. But it's important. I know for so long when I became OT faculty for this program, I would be approached by occupational therapists. And actually, even recently, a doctor said to me when I was doing a support group, well, just PTs do LSVT big. Why would an OT be doing that? And as OTs, as much as there is an exercise component to LSVT big, right? And there's balance elements, we're working on big walking, so gait and all these different things. It really is a viable option to improve occupational performance because we're targeting, all of those areas of meaningful salient engagement that relate to that client in their functional component task, their hierarchy task. And so we even saw improvements in hand function. And what's interesting, I think, about this as well is the study that I love so much. If you guys have, if you've ever said it on a webinar I did, I promise this study was in it, but the Cabrera-Marto study from 2019, where they, compared people doing tasks that were meaningful to them, like putting on a shirt or buttoning their pants. And then the other group did these rote, standard hand therapy type approaches. And the group that did what was meaningful improved so much more, not only in their goal attainment scaling was the outcome in that one, but then also in their pinch and strength. So I thought this was an interesting quote by the author that the top three priority areas that participants identified on that COPM included handwriting, big surprise, right, with the micrographia, lower extremity dressing, so often, that shoes, socks, tying shoes, putting on pants, and then other areas of dressing, and they identified, buttons and manipulation of fasteners. Because these tasks are necessary to perform ADLs and thus fall within the domain of OT, they felt that this finding really confirms that OT should play a key role in the rehabilitation for people with Parkinson's disease. Now, for a lot of you out there as clinicians, that might not be a surprise to you. But I have to tell you, when I first started doing Parkinson's, and really had an interest in it, I was told there was no role for occupational therapy in Parkinson's. It was only PT, it was only speech, it wasn't needed. And because the nature of what we do so much as occupational therapists often is more qualitative than quantitative, I feel like we've had a hard time really showing the impact that OT has in so many conditions, but especially Parkinson's disease. So I thought this quote was important to highlight. Next slide, please. And of course, there's always limitations, right, to any study and more things we need to know. Anytime it's kind of a small, like this was a retrospective study, there was no random assignment. They weren't using a control group to compare this against. It was also just one hospital-based facility that the data was taken from. I think it's important to, note that the outcomes were reported by the treating therapist. It's like you or I in our treatment note, right? Which could include a degree of rater bias for sure. And then, I mentioned earlier the amount of experience that these clinicians had, and always there's individual characteristics and ways that we deliver therapy that can really vary among therapists, even when you're using a standardized protocol such as LSVT BIG. And whether the results were maintained with home practice, like there wasn't a follow-up done, like looking at 6 months or a year out, and we really need more research to explore the effectiveness of LSVT Big on improving occupational performance. So really looking at how this improves function and task, but also using objective performance-based measures. So maybe the pass, or some of these, where you actually view and watch someone doing that task, so that you can corroborate that self-reported improvement.
And
Next slide.
Julia, there were
Yeah,
a few really great comments that came in. So thank
awesome.
you for those. I'll read them to those of you that maybe aren't accessing your chat right now. Practicing salient activities is important. And yeah, this study did a great job of really underscoring that. Implement the tool during evaluation so patient can perceive their own improvements clearly. Definitely agree with that with the COPM. And then I teach finger flicks and hand flicks depending on fine motor coordination, which is more appropriate to the task considering amplitude and effort, and then have them do the task. So all great comments. Thank you.
Excellent. And I think you're up next, right, Laura?
Yes, I am. Thank you.
All
So
right.
let's move on to our fourth and final polling question for tonight. Do you offer telehealth personally? And this doesn't have to be specific to LSVT Big, but just if you're a therapist joining us, do you offer telehealth in your organization or your practice setting? So let me launch that poll. And again, this is a quick one since it's just a yes/no answer. I'll give you 5 more seconds. All right, looks like almost everyone has voted. Thank you. So 46% yes and 54% no. I think that is so interesting. And I bet if I had polled you 2 years ago, that number may have been a little bit different. We've definitely seen a positive shift in telehealth because of the pandemic. So one of the silver linings. So that's great to hear. And the next study we're going to highlight is really about LSVT Big being offered via telehealth. And this is a case report and really only one of 2 studies that investigate the use of LSVT Big either partially or wholly via telehealth. And this one was in particular a gentleman with young onset Parkinson's disease. He was 46 years old and he was at a home in ER stage 2, so really pretty early on in his disease progression as well. And he had had Parkinson's disease for already at least 4 years. He heard about LSVT Big rather soon after diagnosis, but he lived in a rural area and didn't have access to an LSVT Big therapist within 2 hours of him. And so it took him a while until he was able to find someone to provide this treatment via telehealth. His complaints were tremor of his right hand. He was having problems with dexterity of his right hand and slowness with functional activities, also reduced vocal production. It didn't say in the study if he received LSVT loud or not, but that would be something I would think about. And because of these dexterity issues, it affected his ability to do recreational things like table tennis and also writing and typing, which he did quite a lot of for his work. He managed an IT company, and he was the father of 5, so very busy man, independent with everything despite his Parkinson's symptoms. His concerns were anxiety about his diagnosis and disease progression, as you can imagine, being able to sustain his ability to work and provide for his family. And to achieve that, he really wanted to be able to improve his right hand speed and dexterity. So the measurements that were selected were the 9-hole peg test, the mini best test, the 10-meter walk test, the 30-second sit to stand, and the UPDRS Part 3 motor scores. This is an open access article, so you can find and download the whole article or read it online. I've put the URL here. And also I should note too, at the end of the webinar, there are 2 slides that have the full citation. So if you want to download the handout, you can do so. It was emailed to you, but you can also find it in the control panel in the handouts tab so that you can find the link and access that. So this one was published by Willow Henry et al. And her therapy students, her physical therapy students. So here's what they did. They did the initial examination and the discharge examination in the patient's home. So it was definitely, hands-on. And as part of the examination, they also looked at the patient's space and found the ideal place for him to participate in the LSVT BIG treatment via teleconferencing. Because of his work being in IT, he was super familiar with teleconferencing, so he really didn't need any training in that aspect, and he had all the equipment that he needed as well. Willow Henry also indicated that they used an additional camera for more wide-angle views of him while he was doing things like hierarchy and big walking, but he was able to easily switch back and forth between his webcam and this other external camera. They did LSVT BIG per protocol, which, as you know, is 4 times a week for 4 weeks. He missed 2 visits. I believe it was day 13 and 14 because of insufficient bandwidth of his internet provider during those 2 days, unfortunately, and wasn't able to make those up. The treatment was provided by LSVT BIG certified PT students under the supervision of an LSVT BIG certified PT. And in terms of what they did, it's detailed quite nicely. Every day is listed in a very nice chart in the study itself. If you download that, it indicates how they progressed his maximal daily exercises by adding counting, flicks. They had a foam balance beam, which they had provided to him to use, as well as cuff weights. They added cognitive dual task challenges, and they did that in a progressive manner over the 4 weeks of therapy. His functional component tasks were sit to stand. They did some mock table tennis. They did an activity where they pulled the chair out, and he pulled the chair out, and he had to sidestep to the left or right. And then they did a bilateral fine motor grasp activity where he had to grasp and place something. His hierarchy task was timed handwriting and shape drawing. And in terms of the big walking, it was a little bit limited by the space that he had in his room, but they did at least 2 to 4 minutes every session working on forwards and backwards walking. They added a yellow band for resistance and worked on that as best as they could. So here's the results of those. You can see his scores at evaluation for all of those outcome measures and how those improved at the end of the treatment intervention, which was at 4 weeks. You can see that in the mini best test, the MDC and the MDIC were not met, but they were met at 6 months out, which I think is kind of interesting. And he actually showed trends towards improvements at 6 months out at the follow-up. In terms of the 10-meter walk test, that was met and also maintained at 6 months. The 30-second sit to stand, he exceeded the minimal detectable change and again continued to improve at his 6-month follow-up. His 9-hole peg test improved. It was the MDC was met with his right hand, but unfortunately he did not maintain that at 6 months. And his UPDRS 3 score improved a little bit, but not as much as it needed to, which was 5 points to make that cutoff for the MDC. This is a quote that I pulled from the study I thought was quite good, that he had increased ease and amplitude movement patterns, most significant change in gait, posture, and energy level. Patient and family noticed better voice volume during conversation. At work, he noted improved typing and handwriting ability. And most importantly, he described the ability to think big. So you think that this man is probably calibrated. The patient was grateful to be able to access treatment in his own home without the barrier of a 2-hour commute he would have faced with in-person treatment. And I know that, this is a significant barrier for people that live in rural areas or maybe a distance from an LSVT BIG certified clinician. So same thing as last time. If you want to, we'd just love to know your thoughts about what's a way that you could apply this to your patient care currently, and maybe you haven't started LSVT Big via telehealth, but you've thought about it. You just haven't jumped off that cliff yet. Clinically, here's some areas of relevance, I think. We know that there's barriers to receiving intensive treatment like LSVT Big, especially for people with in rural areas. Maybe they are in a place they don't have an LSVT Big clinician nearby, even if they're not in a rural area. A lot of patients with PD have transportation barriers. And some people, like this gentleman, is busy working, raising 5 kids, and really squeezing that hour a day in is more burdensome if they have to add on commute time as well and schedule around their work hours. So there were positive objective and subjective improvements noted in this case. And, for a lot of people during this pandemic, when they can receive LSVT Big or therapy for any thing at home, it really reduces their risk of exposure to COVID-19. Now, telehealth isn't really for everyone, and we all know that. In LSVT Big, it's a very hands-on treatment. There's a lot of physical shaping that's involved that you can't accomplish when you're not seeing someone in person. You're seeing them only virtually. So in this case, they really found out that they had to use extra modeling, extra visual and verbal cues when they weren't able to physically shape. In this case, this patient wasn't at fall risk, and he was able to safely do the activities in standing and even have balance challenges, and felt good about his balance reactions. But certainly for people that might be at fall risk, you would want to identify what their fall risk is and adapt any movements, adapt any exercises to sitting or even supine or standing, hanging on for support, maybe have a caregiver or helper there as well for safety. The patient needs to be familiar with technology. In this case, the client was very familiar with technology, and they have to have adequate internet bandwidth and speed as well. And as we all know, internet bandwidth is more of an issue now with more people staying at home, working from home, and always challenges in that area as well. Definitely some limitations, just a case study, so we can't generalize this to all people with Parkinson's or all people going through LSVT Big would it be appropriate for telehealth. We do need larger sample sizes, comparison of outcomes to in-person treatment needed. They have some studies like this in LSVT Loud, and I think it would be fabulous to have parallel studies in LSVT Big comparing in-person and telehealth treatment. And it'd be great to also determine how people with moderate to more advanced PD would do with telehealth. So let's just take a look at some of the chatter that came in here. All right, so one says, great study. I deliver Big for Life group virtually now. Great. And do note limits in camera views with walking portions. Definitely. Any ideas to get more creative with limited camera views when doing big walking via Zoom? Really, really challenging, especially if the person has a limited space. They can't really get away from the camera as far as you'd like, but definitely different directions, short distances, working on quick stops, quick starts, dual tasking, walking in place. There's lots of different things that you can do, I think, even in a limited space, working on obstacles, working on doorways, and then seeing, is there also anyone in that environment that can help them by, carrying their laptop or their device around so that you can watch them at least from room to room. So just a few ideas there. Another comment about using hierarchy tasks in telehealth. Okay, so let's pass it back to Julia, who's going to walk you through the next two studies.
Excellent. Thanks, Laura. So this is a looked at the short-term effect and retention of LSVT BIG on quality of life. So they were really focusing on this 1-year follow-up of a patient with Parkinson's disease. And so basically they evaluated both the short-term effects, so immediately following completion of LSVT BIG, and then also looked at this a year out. So they were basically tracking, and really the focus was on motor symptoms, walking ability, and walking speed were factors that they felt were associated with quality of life for this individual. So this was a 63-year-old female who'd been diagnosed with Parkinson's disease and had a Hoehn-Yahr of stage 2. And they were using the Hoehn-Yahr to track disease severity, but then they used the PDQ-39 to look at quality of life. The MDS-UPDRS, and I think this was also the motor scale, and then the timed up and go, and then the 10-minute walk test. Next slide, please. So once again, they were doing the 16 sessions of LSVT BIG, and in this case, it was delivered by a physical therapist per the protocol. The physical therapist did note that they were really focusing on maintenance of this Borg scale, that the client was keeping up with that 7 to 8 out of 10 throughout the delivery of the protocol. They noted that the patient had a mini mental status examination of 30 out of 30. Something to note for all of you, just in case you don't know, is the mini mental has not been shown to be sensitive to changes in mild cognitive impairment in Parkinson's disease. And often around a Hoehn-Yahr 1 or 2, that's what we're going to see. So your MoCA is really more sensitive for the most part. That's generalizing in the research, but I know now that they do charge for use of the MoCA, and that is a limit to some people. But that's just something to think of. Is that I just wanted to point out, this does not mean this patient might not have some changes to their cognition in a mild way. The participant was demonstrating rigidity, notably bradykinesia, and also gait impairments. And their functional component task included sit to stand, stair climbing, stepping over obstacles, turns, and then one leg standing. And I just, and this is something you guys can type in the chat or not, but kind of, really thinking about, are those really functional component tasks? If we're looking at like stair climbing, stepping over an obstacle, I think some of them are for sure. One leg standing, is it really? I mean, one leg standing to do what? I was trying to think of why this person might need to stand in balance on one leg. So I think it's something, when I look at these studies, it's always a reminder to myself of like really thinking about the why of what I do. Because I was trying to understand and reading some of these, like, why was that what they chose? And there might be a really good reason for it. And then they also, the hierarchy, and Laura and I were discussing this before we came on, was walking long distances while holding a conversation. Well, is that really a hierarchy task? Or is that really more practicing big walking? So I felt that in this study, there was to me, it's a reminder to really look at the why and what we're doing, keeping things functional. And, not that walking long distances is bad, but imagine if you're doing that as the walking task, and then they've got those 1 to 3 hierarchy tasks here. How many more chances you get to work on that calibration and on that sensory motor connection. Next slide, please. So the results, they did notice that there were short-term improvements across most of the domains. So there was a decrease in the PDQ-39, and with that and the MDS-UPDRS, lower scores are better. So that's actually a significant improvement. The MDS-UPDRS Part 3 was a decrease from 30 to 22, and so they noted an improvement in bilateral toe tapping, also leg agility, gait, and bradykinesia. They did not see an improvement in rigidity. With the timed up and go, there was a decrease from 9 seconds to 7.2 seconds, which isn't within the minimal detectable range, I believe. But I mean, still, it started out, it was good to begin with a 9 seconds. So definitely that was still, she at least maintained or did a little better. And then with the 10-minute walk test or 10-meter walk test, there's an increase from 1.3 to 1.37 meters per second. So you can really see where there were some significant improvements. So then they did a follow-up and looked at this. Oh, sorry, if you could go back. They did a follow-up after a year and found that there was a further improvement in the PDQ-39, which is really interesting because this really speaks to self-efficacy, right? And someone really calibrating and being able to move forward with this. The MDS UPDRS was maintained, and there was a little bit of an improvement from 22 to 20. The tug, there was still a little bit of a decrease that happened from there, and then also a slight increase even still in the length of time with walking. And I love this quote: "It became easier to walk, and moreover, I can walk with my husband." So the one thing that was really missing, though, just to note, is they didn't really say what they did to track continued performance of the homework protocol or what they did to do it. Was it, kind of a park fit type approach? Did you do some goal setting or scheduling? So I would have loved to have known that information. Next slide, please. And so type in the chat here, what is a way that you think this study could apply to your patient care? And I think that when we're looking at things like this in a critical sense, not just maybe were there things I did right that you think could inform, or there are things like I said where it's like, I got to really remember to keep my functional components functional or try to get those hierarchy tasks in. Whatever you think is relevant for you, that's what I think, you should really look for in the research. All right. So the relevance, this was just a case report, but it suggests the possibility of really retaining those improvements in quality of life, in motor symptoms, in walking ability and speed with LSVT intervention in a patient that has mild Parkinson's, right? And it's important to note that these improvements in retention may be due to that sensory motor calibration, that the program is so intensive that there's multimodal exercises that are really improving movement patterns and that continued home practice. And then the short-term effects of LSVT intervention improved almost to the same levels that we've seen in previous studies, like that Farley and Koshland and the others noted here. And another nice quote: "I'm able to walk easily, and ease of walk adds comfort to my life." So I think really remembering how important, these things are to our clients. Next slide. So limitations, of course, this was just a single case study. There was no control group, and we really, I think, need a randomized controlled trial to determine how this intervention, would compare to other types of therapy, and also if we would really see that retainment of skills in that amount of time. All right. Oh, and then this one's mine too. So looking at motor symptoms after LSVT BIG in a patient with severe Parkinson's disease. And I have to, note that I think this is so important. I just worked on the practice guideline for AOTA, and it was one thing we found a huge gap when we were talking about gaps. Most studies really exclude people who are in advanced disease state. But then when we teach LSVT big courses, what we see so much are clinicians coming in that are like, my patients are in the advanced stage. I'm in a skilled nursing facility or I'm doing home care. And so a lot of times there's not a lot out there. So this was a 77-year-old woman with Parkinson's. She was a Hoehn Yahr 4. She'd been on Parkinson's medications for 25 years. She'd have 12 falls in 6 months. She used a four-wheel rolling walker indoors, but she had to have assistance or supervision to be able to walk outdoors. She used some adaptive equipment for ADLs, and she needed assistance from someone for bathing and drying, doing meal preparation, and also shopping. The measurement, once again, they use that motor scale of the UPDRS-3, the 10-meter walk test, or 10-minute walk test, the Berg balance scale, and the 30-second chair test. And they did a pre and post with this. Next slide, please. And so once again, it was delivered per protocol. Of course, that 16-session LSVT BIG protocol of 4 sessions a week for 4 weeks. And these were by certified physical therapists. I want to point out, it said, that per the LSVT manual, weeks 1 and 2, the exercises were done in sitting. There is no standard protocol for how long someone can do the exercises in sitting. And I'm not sure if that was an issue of translation, but I just wanted to clarify that someone might need to do the exercises all 4 weeks in sitting, and that's okay. And then it said weeks 3 and 4, the exercises were performed in standing. Didn't specify if this person was standing assisted, but I have a hard time believing that someone Honan Yar 4 is going to go from sitting to just standing and not holding on to anything. The functional component task, one was stepping over an obstacle in sitting. Once again, I was trying to figure out what that might be related to. Upward reaching, and there was really no mention of why this person would need to reach upward. Clasping and unclasping hands, once again, no real relationship, because it really identified that walking and using chopsticks were what the main issues were. And also, I wanted to note too that the motor symptoms for this individual were bilateral rigidity, bilateral resting tremor, freezing of gait, bradykinesia, and also hypomemia. And balance impairments were reaching forward and being able to turn and look behind. So that if you notice here, the functional components, we've got the obstacle, the upward reaching, clasping hands, and then with sit to stand, they talked about using visual and auditory cues. So I'm looking at this and going, well, where was the freezing of gait? Where were some of these things that we needed to work on, and really need more goals to work from too. The hierarchy was walking to a table and using chopsticks to pick up noodles, because this woman had a hard time keeping the food on the chopsticks. It would slide off. And then big walking, it said they worked on walking with larger amplitude, arm swing, and stride length. Next slide. So once again, an improvement in the UPDRS, right? The 10-minute walk test improved. All of these are, meeting that minimal detectable change. The timed up and go, significant improvement there. Berg balance scale, the 30-second chair test. So you can see all of the improvements. And this is someone really, pretty advanced in their disease state, but did very well. Next slide, please. So, what is one way you think this study could apply to your patient care? Kind of think of that. And one that comes to mind is often, when we get new clinicians or clinicians who are new to LSVT Big, and they're like, "Oh, my client's going to need so many breaks, and they're going to need to rest." And like this client, I should have noted, had been doing exercise sessions, I think like 2 times a week, that focused on like stretching, but it was not intensive exercise. And I think often we think of someone in advanced disease state as not being able to, or they're going to get so tired, or maybe it's really going to be too much for them. And I think you really see that, maybe it was really needed. It seems like that they can tolerate this, and not only tolerate it, but it's very helpful. So it harkens to a lot of what we're hearing around therapy, of really, pushing our patients more. All right, next slide, please. So the clinical relevance, this suggests that LSVT big can really improve motor symptoms, even in a patient with severe Parkinson's disease. And so that increased intensity can help people with severe PD. And these are some quotes from the client: that it became easier to walk, and especially to take a forward step. And I have a feeling that's in comment to that freezing of gait. And also, it was easier to use chopsticks, so the food wasn't slipping off the chopsticks. So those are those functional things, and I would have liked to have seen more of that in this article, actually. Next client.
And
I mean,
Julia,
next client. Yes.
I'll
Yeah,
jump in and just share a few great comments that came in. One was, don't give up on patients. Yes, absolutely.
absolutely.
Implement LSVT right away, even advanced PD.
Yep.
Great that we're looking at the research regarding advanced stages on the Hone and Yar. And then a couple comments about from the last study that were really good too. One therapist notes that she works on single leg stance related to putting their pants on and incorporating that. So definitely that could be a good thing if you practice it with the pants. And then one last question or comment about that last study about the early PD and the long-term results. I think it also supports the benefit of trying to encourage patients to participate in Big for Life programs as well. Imagine the potential benefits of regular ongoing LSVT guided recreational exercise. So absolutely.
Absolutely, good point.
All right, and I think that was it for those.
Yeah, yeah, I think these just, the limitations are pretty similar to what you've seen before. And I think you've got the last one, Laura.
Okay, all right, so thanks. And we're gonna go fairly quickly through this last one because I do want to use a few minutes of our time to address any questions or comments that you have on these research studies or other topics that you might think of. So this last one came out of Germany and it's called Effects of LSVT BIG and Conventional Physiotherapy on Non-Motor and Motor Symptoms in Parkinson's Disease, a randomized control study comparing 3 exercise models. So they wanted to investigate the effects of LSVT BIG, intensive physiotherapy, which they called intensive, and then conventional physiotherapy as it is related to conventional physiotherapy in Germany on non-motor symptoms in Parkinson's disease. So they had 44 people with mild to moderate Parkinson's disease and randomized those into 3 groups. And, I should also note that we know that looking at non-motor symptoms is very, very important. We know that people with Parkinson's often find these symptoms as the most disabling. And we also know that exercise may have some impact on some non-motor symptoms in PD. So they were looking at differences in change in the non-motor symptoms using the NMSS between groups from baseline to follow-up at 8 weeks. And this one is also an open access article, and I've listed the URL here. The subjects that were included in this study were those with early PD, stages 1 through 3 on the Hoehn and Yahr scale, and also people that didn't use any walking aid. Some of the exclusions that I think it's quite important to note were people with dementia, people with depression, those on antidepressants and antipsychotics, those who had had LSVT BIG in the last year, and those with disabling bradykinesia, and people with advanced PD as well, who may be more apt to experience non-motor symptoms on a greater severity level. So they did LSVT BIG. It was one therapist that did LSVT BIG 4 times a week for 4 weeks in an outpatient hospital setting, and there were 14 in that group. In the intensive group, it was also provided at the same frequency and dosage, but by 3 physical therapists at the same hospital, and there were 15 in that group. And for the normal group, it was provided 16 sessions still, but at 2 times a week for 8 weeks by PTs of their choice, meaning of the patient's choice, in any local office practice that they chose. And there were 12 people in that group. The primary outcome variable was the non-motor symptom scale. They were looking at the change from baseline to 8 weeks. And you can see here, I won't list them all, but there were a lot of secondary outcome measures that they looked at as well in this study. They looked at within group changes and also between group comparisons. If you're not familiar with NMSS, it was given by a blinded rater as to group allocation, and there's actually 30 items that are grouped into 9 different dimensions. So there's 2 questions related to cardiovascular, 4 on fatigue, 6 on mood and cognition, 3 items on perceptual problems, hallucinations, 3 on attention memory, 3 on GI problems, 3 on urinary issues, 2 on sexual function, and then miscellaneous, there's 4 items, and then they score them, and they're based each one on their severity level from 0 to 3, and their frequency from 1 to 4, and then the range of total scores could be anywhere between 0 to 360. So they had 44 altogether. They indicated in the study that they actually needed 60 to be adequately powered for the NMSS, and they were not powered to assess the secondary outcomes validly. So here's the results. They found out that all 3 groups had improvements on non-motor symptoms. The intensive group was superior to normal in non-motor symptom reduction. They found in this study that LSVT BIG was not superior in non-motor symptom reduction as compared to the other groups. There were significant changes in depression symptoms found in the LSVT BIG group only, and there were significant changes in cognition within group in the intensive group. And I thought the quote was quite good. It's difficult to conclude whether intensive physiotherapy compared to LSVT BIG and standard care is superior in ameliorating these specific symptoms in Parkinson's disease, which might also be impactful with regard to quality of life. So let's take a look at some of the clinical relevance for us. I think one of the things that was highlighted in this study is that high intensity, high frequency PT was found to be more effective than lower frequency PT in reduction of the non-motor symptoms. And those symptoms are, like I said before, disabling in quality of life in people with Parkinson's disease. So they shouldn't be dismissed as unimportant or less important than motor symptoms, because actually they're quite important. There were a number of limitations in this study that we found excluded people who may have shown benefit in reduction in non-motor symptoms. So it excluded those from the get-go that already have depression and dementia, those with advanced Parkinson's disease. The outcomes in the LSVT BIG group might be affected by the impact of the skill and experience of that single therapist who provided all the therapy as compared to the 3 therapists that were more experienced in the intensive group. The treatments weren't really described very well or very thoroughly. The location of the intervention was different for the normal group. The groups were underpowered for both primary and secondary outcomes, and so very difficult to generalize the findings. And the patients were not blinded, so they might have been biased thinking that one treatment was superior or inferior to another, and they lost the training adherence records as well. So some future recommendations, RCTs are great. They're very powerful. They can be when they're done well, written well. And it'd be really wonderful to have RCTs that compare treatments with larger group sizes that are adequately powered. And looking at really specific non-motor symptoms versus global non-motor symptoms that are more likely to be impacted by therapy. Be great to know if LSVT BIG or any other therapies impact these in people with advanced PD. As Julia said, a lot of studies exclude people with advanced PD, just like this one did, but they're the ones to be most impacted by non-motor symptoms. Is there an ideal minimum dosage and frequency for people with Parkinson's in each stage of PD? And again, does OT have a different effect on non-motor symptoms in people with Parkinson's disease? So it's just some of the questions here. I won't read through the summary here. I think they're quite reflective of the learning objectives and things that we've discussed tonight, and I'll save my breath here and let you read those so that we can get to some of your questions and comments. You can ask questions probably most easily by typing them in the chat box in your control panel like you've been doing throughout the webinar. You can raise your hand if it's lengthy or just easier for you to ask your question out loud. If you think of something later, always email us at info@lsvtglobal.com and it'll be forwarded to one of the LSVT BIG faculty. So let me just open our question panel here. Yes, a couple of comments from someone in acute care. Try to integrate CEUs based on LSVT BIG, can't do the full program. Right. But there's some things you can definitely do in acute care: screening, educating, helping with disposition planning if they're appropriate for LSVT BIG, identifying someone in the next practice setting, and that might be able to help them as well. So really, really important role for acute care therapists. Okay, just scrolling down here. Thank you everyone for your really great input tonight. I think it makes it a lot more fun when we've got some interaction. All right, I'm glad to hear about the non-motor symptom improvement. My mom had non-motor symptoms rather than motor. Yes, I wish I had been certified at that time, though I did do some large amplitude exercises. Great. And those non-motor symptoms were very disabling in her quality of life. Very much so, totally agree. And I love it that we have the potential as therapists to make some positive impact on those. Um, Another comment, experience of the PTs providing the exercise may affect non-motor symptoms as well, and this was not controlled. Yes, thank you for that as well. I think we all know that occupational therapy and physical therapy are a science, but they're also an art. There's just a lot that goes into it. And definitely, I think as our skills grow as therapists, our impact lately grows with patients, and not only motor impact, but non-motor impact as well. All right, Julia, did you see any others come in while I was talking that I missed so far? Otherwise, we'll stay on for a couple more minutes and let you type in your questions. And while you're
Me?
typing in, yes, go ahead, Julia.
Oh, no, not that I've seen. I think you got
Okay,
everything. Yeah.
okay, good. You still have time. If you're want to type in a question, you still can do that. While you're doing that, I'll just tell you about next month's webinar. January 2022. Can you believe that? I really can't believe that. But we are going to take a step back in time and we're going to talk about the origins of LSVT BIG and how they shape the effective treatment we deliver today. We get a lot of questions from clinicians like, where did this all come from? Why do we do these 7 specific exercises? Why is it 4 times a week for 4 weeks? Why is it structured the way it is? And we're going to really dig into that a lot more than we have time for in the certification course. So if you find this interesting, you'll learn about this. This will be Monday, January 24th, 2022 from 8 to 9 p.m. Eastern. If you're an LSVT BIG certified clinician, you can register for this from your LSVT clinician account. It might not be in there quite yet, but it will be soon. So coming soon with that. All right. And then if you think of any questions in the future, here's our email address and our website. Don't forget about the survey, and also that we've listed the full references here as well for you that you can find in your handout. So let me check these questions one more time. And I think we got them all. It looks like no others came in. It was nice to be able to chat during the webinar. So Julia, thank you so much for your presentation of those 3 articles tonight.
Same to you. Great job. This was a lot of fun. She knows what a geek I am. I love any opportunity to talk about research.
Yes, Julia is the star on the team that loves research. So thank you all for joining us. We hope that you enjoyed the webinar as well. We wish you all a wonderful holiday season and end to your 2021, and we'll see you next year in 2022.
Take care. Good night.